Hello, my name is Dr. Jeffrey Barsuk. I am the Robert Hershtick Professor of Medicine and Medical Education at Northwestern University Feinberg School of Medicine. I currently serve as the Executive Medical Director of Northwestern Simulation. And as usual, I'd like to welcome you back to another podcast in our series on simulation and healthcare education. Today, I have the distinct honor of interviewing Dr. Pamela Jeffries. Pam is an internationally recognized leader, researcher, and innovator in nursing and healthcare education. She currently serves as the Valere Potter Distinguished Professor of Nursing and the 9th Dean of Vanderbilt University School of Nursing. Pam, it's an honor to interview you today.
Well, thank you.
We usually start our podcast with a little bit of background about how you got involved in simulation.
So this is quite interesting because I'm in DC at the moment, and I reflected back. It's been 20 years when I first had. I was a project director for the NLN and the Laerdal Foundation when we were embarking on simulation research. And believe it or not, we're celebrating our 20th anniversary this week. So very timely, and I've been reflecting on that. But how I got started in simulation was I was actually at Indiana University at the time as a faculty member and teaching students in a lab, teaching them skills and critical thinking and all that. But it was a lot of very passive learning. Students would sit, I would demonstrate, they would sit almost fall asleep. It was just not fun at all. And I thought there's got to be better ways. So I started reading the literature, and I read Barrow's work and started looking at standardized patients and how we could do experiential learning and immerse students in these scenario-based events and encounters. So luckily at IU, I had a medical counterpart, Dr. Scott Ingham. He was a pediatric surgeon, and we wrote a grant and got our first mannequin, our first simulator. And then we started doing a few interprofessional simulations with third-year medical students and nursing students. And then from there, I took it into the lab and did some OSCEs. Students had to test out of some of these skills, but instead of just saying do the medication administration, insert the Foley catheter, I created a whole scenario around it where they had to do the task and then evaluate, etc. So that's how that was all born. And I really enjoyed the experiences with students and saw the light bulbs come on, quite frankly, on in a much deeper, more comprehensive understanding. So that's how I first got started. But then also I was National League for Nursing put a call out for a program director because they wanted to conduct simulation research. So I applied for that. I got it. And there I was working with 8 different coordinators. And there was a major representation from baccalaureate programs, associate degree programs, and 1 diploma program. And it was interesting. They wanted us to do simulation research. Well, it wasn't like I had, 8 to 10 researchers. They were all representatives from different programs. But anyway, long story short, we could have made it simple and done 8 outcome studies, very simple. But the more I got into this, and it was embryonic at the time, the literature would say simulations were being done, but they never said how to do them, or some of the major ingredients, or what was the major simulation design you needed to do to set up a simulation. So, and nor did I know the theoretical basis, and this was put upon. So being the good academic I am, I thought, we're going to do this. We're going to set up a framework. We looked at the literature, looked at the theories, and came up with the first, if you look at it, it's the NLN Jeffries framework that came out, I think it was in 2005, 2006 when that first came in the literature. And then we started testing components of that framework, and lo and behold, it's still pretty true to the core today with those components. But that was based on a very strong literature review, the work, the test, and all of that. And then it became a theory, and I'll talk about that shortly.
It's hard to believe that was just 2005, 2006, right? Because we've only been doing this for less than 20 years and even doing it right for even less long than that. I'm really interested. Let's talk more about the Jeffries simulation theory, because it's really a major contribution to the simulation scholarship literature. So tell me a little bit more. You said that you did a literature review and developed this theory. Let's talk and do a deeper dive into the theory if we can.
So thanks for the question. So we had the framework when working with the 8 program coordinators across the United States with geographic representation, north, south, east, west. We put this framework out. And then in I think it was 2005, 2006, we actually wrote a book. I call it the cookbook. It had several chapters on how to do simulations and what the best practices were at that time. Debriefing was a big component. So it was just literally the ingredients, the cookbook on how to set up simulation, because we didn't have that. So we wanted to give back to the community embarking on simulations. So we would, this book was written and people would write me. We also developed a couple of tools, one on self-confidence, one on satisfaction at the time, really low level measures on evaluation. But at the time we were trying to keep it simple because we didn't know what we were doing. We were just starting out, right? And then we use those tools and there was one on simulation design scale too, that would help tell us whether the design was correct or we were leaving an ingredient out. So anyway, the years went through, a lot of people started using the simulation model, the framework, and it helped guide their research. In fact, I think one of the most things I'm proud of, that the framework and then theory, which I'll get into, it served a lot of our graduate students' needs. Many nursing students and other health professional students use that simulation model to ground their work when they were conducting some scholarship and teaching and learning using simulations. So then fast forward, it was probably 2013, 14, working with colleagues, and this is through INACSL, the International Nursing Association of Clinical Simulated Learning. They came to me and said, "Hey, Pam, we would like to dissect the model more, and we believe it can be a theory. It's not just a framework, it's just not a model." So at that time, we worked with Beth Rogers. She's actually a theorist. And if you look at the points in theory, you have to have relationship statements. There's components you got to look at and establish to say, yes, indeed, this is a theory. So there were groups at INACSL. A lot of them are my really good colleagues, friends, simulationists all over. And there were 5 different areas, subgroups looking at that. And lo and behold, they deemed this a mid-range theory. It's like, yes. So I did not do all the work on that. There were colleagues saying this needs to move to a theory. And then the NLN partnered with INACSL, and we have the NLN Jeffries Theory monograph that was, I think, first printed in 2015, 2016. I just did an update, I think, in 2021, the second edition. So it's out there. And again, very, very proud because our doctoral students, our master's students, they have now a theory that is grounded in a theoretical basis, which is the constructivist learning theory, the sociocultural learning theory, because you're going to have these external aspects as well.
Let's start talking a little bit about excellence in nursing simulation, because there are a lot of unique problems, as we should say, or at least issues that are having to be dealt with in nursing that may not be dealt with in other specialties. And I'm certain that you're facing some of these as the dean of the Vanderbilt University School of Nursing. So what are the top priorities right now in nursing simulation education?
So again, thanks for the question. The top priorities in trying to integrate simulations in nursing education, I'm going to talk broad. I'm just not going to talk Vanderbilt, but broadly. And that would be, one is faculty development. People who embark on simulations, you want them to be developed. And in fact, there was criteria that came out, and I'll just briefly mention this. But 2014, 2015, I was part of the National Council State Board of Nursing landmark study. Dr. Susie Cardenegrin and myself, we were consultants, full disclosure, working with the NCSBN to really, it was a multi-million-dollar study looking to see if we could substitute simulations for real clinical time. Because we couldn't. Many people said at that time in 2014, 15, people said simulations. I don't know. I'm not going to count that as clinical hours because I don't know if they work. Anyway, this study was conducted with a control group, 25% SIMS allocated, or 50%. When I say 50%, say if I had 100 hours in pediatrics, 50 hours would be in simulation space, and 50 hours was real pediatric patients. So it was a 1-to-1 ratio. Anyway, that study was conducted. It was multi-year. We got tons of data, 10 schools of nursing across the U.S., have project coordinators. I couldn't be more proud to be a consultant on that because guess what? We proved that simulations work, and we could stop that conversation saying they don't work because there were no significant differences in NCLEX, because NCLEX is our state board of nursing. They were still passing it. Also, they were conducting, it had the clinical skills, they had the clinical reasoning. And in fact, in looking at knowledge measure in some of the specialties, whether it was psych mental health, whether it was pediatric, maternal health, scores in the knowledge and assessment were higher, significantly higher in the 50% group than the 25% in the control. What that told me, we were standardizing those experiences, right? I mean, take maternal health. How many times do students, you take them to an OB unit? Hopefully they don't see postpartum hemorrhage. Hopefully they don't see a lot of negative things, but happy births. But in the simulation space, we can set up those high risk, low volume events, and students are prepared for these. But and as you know, Jeff, with probably medical education, the gold standard is always patient care, right? Over in the clinical, the same thing that we've always done. But there were significant differences there in that. But anyway, going back to that study, that made such a difference because the priorities came out, what was needed to develop and integrate a simulation-based curriculum in nursing education. And what happened, there were policy implications that went across 50 states because our nursing is all dictated by state. State of Ohio may be different than Delaware, than different than Indiana or Tennessee, wherever. But this study helped inform board regulators on what to require if you're going to have a simulation-based curriculum. Now, going back to priorities, your question, and that is we need faculty development. During this study, this whole landmark study, we developed all the people from the 10 schools that ran the simulations. We had a simulation team. So we said, up to 50% could be substituted for real clinical, but there's caveats, right? As long as the faculty were developed in that, as long as you have the proper resources and support, because you can't put 120 students through if you have one mannequin and trying to get everybody through. So you have to have the proper support. But today, Jeff, when you ask priority, faculty development is still a high priority. Everywhere you go, some people know 1/3 the information they need or 30%, but they need much more. It needs to be more comprehensive. And so I would say development is still sparse, even though there's pockets. People go to conferences, they hear this, that, but you really need to be immersed and develop faculty in the pedagogy. Because it's not even just about the mannequin, it's about the pedagogy, it's about the art of debriefing, it's about setting up a good simulation, whether it's a simple to complex, and what those problem-solving events, components are within the scenario. So that's all really, really important. I think the second priority is getting simulations integrated in a curriculum, not just one off here, one off here. That's really hard. I mean, that doesn't really make such a difference, does it? If I had one sim day out of a 15-week semester, okay, so what? It's like, how can we integrate that throughout, whether it's 3 to 4 times in the semester? And again, be very selective on what you're putting into your simulations, which, looking at the faculty, what does that look like? And so those are a couple of two priorities, and it also came out from the NCSBN. There's a paper on that. There's a blueprint that talks about it on what is needed. And then I would say the future, what we're looking at, that we're going to be confronted with, and it's probably a good thing. It could be, people are kind of cautious about it, but the use of more technologies, the augmented, the AI coming in. How are we going to use AI? Are we going to incorporate those healthcare tools using AI in our sims? Are we going to use AI to write our simulations? How we ensure accuracy? And are we going to critique them and then run them? And, so that's going to embark, and it's going to be a very big disruptor, as it already is, in higher education and clinical education.
And some of the technologies still being developed. I had the honor to do a podcast with Michelle Abersold at University of Michigan School of Nursing, and she was talking about some of the innovative ways that they were integrating AI into nursing education. And if you look at it, it's still very rudimentary. I mean, sky's the limit, of course, but a lot of the simulator and the equipment's not there yet to bring us to the next level so we can use it. And then this brings up the other issue, is how do you pick and choose? Because, as you know, to develop a curriculum around a simulation takes a lot of work and time to make it rigorous with measurement and assessment. So based on that, how do you pick and choose what you're going to teach? And then again, with the unknown of the AI and where it's going to go, how do you pick and choose through that?
Yeah, no. Well, I think faculty, they have a lot of responsibility. If I'm teaching, say, a med-surg course, then faculty dictate the curriculum, the course. Then what are those major components that you want to ensure that 100% of your students have in this med-surg course? So, for instance, and I did teach med-surg cardiovascular, that was my practice area. For sure, with all the cardiovascular disease, the number one, killer in the U.S. or whatever, I want everybody to know how to take care of an MI patient, congestive heart failure and an arrhythmia. So in that unit, when I'm covering cardiovascular, I'd probably want to set up simulations in that because that's going to make sure that my students, they don't have to randomly look on a clinical unit. Some may get a care of an MI, some may not, but here I can standardize that and set that up. So what are others? There may be high risk, low incidence. They never occur, but if they do, you better know what to do. And that could be the cardiac arrest, right? Again, I'm still back in med surg or whatever. But to be practice ready, I should know what those volatile areas are and be prepared. I don't have time to look around or whatever. When I transition to practice, I need to be aware of those volatile issues and how to perform.
And this gets into, I know a topic that's on your mind is the requirements for competency-based education that are emerging in nursing. So when we talk about picking and choosing what you simulate, I think you have to pick and choose with the competency-based dimensions and the requirements that you're now required to fulfill. And how do you do that?
So that's a very hot topic. So that's not even future, that's now into the future. Our nursing leaders, our educational priorities really shifted for clinical education, moving to competency-based outcomes. At level 1 is pre-licensure, level 2 is graduate. And that was voted on in 2021, and we still have faculty educators, how are we going to do this? What are the metrics? How are we going to measure competency-based outcomes? When I first heard it, I thought simulations, it's got to be through sims. So I see a strong role in simulations for that. And if you look, those competencies, there's 9 dimensions of those competencies with sub-competencies underneath. So using simulations, and you've done this too, Jeff, if you build one simulation scenario, you can have 3 or 4 concepts within that one simulation. whether it's about professionalism, communication, whether it's about pain management and cultural competent care. I mean, you can have all that in one encounter, right? So how do we build those, and then have the right metric that's reliable and valid to measure that students are indeed obtaining these competencies? So that can be done. But early on in some of my work with the National League for Nursing, and when we were looking at high stakes simulation, and do we critique, do we evaluate, how do we evaluate for high stakes? Because that's, students could fail out of the program, fail of course. What we found with high stakes evaluation and simulation, I'm just inserting this in here because probably your viewers will know this, but anytime you're going to evaluate a high stake or a competency like that, it's getting the inter-rater reliability. If you have several evaluators, how are you going to make sure we're all evaluating in a consistent, equitable way, right? So that all has to be thought of. Well, that's a whole nother step in getting that inter-rater reliability met, because we may have 120 students, 150, 100 students, and so they all need to be evaluated in an equitable way. So one other point in nurse, and maybe you're going to get to this, is the funding sources. I mean, recently HRSA, federal funding came out, and one of the big grants, just months ago it came out, was about simulations. And I can't remember the exact call, but it was all around simulation. And quite frankly, when I saw the call, I thought, this is perfect. This is great, because they were asking how we're going to use simulations and integrate them and then evaluate them. So, now the question would be, is HRSA looking at this to look at new models on how to evaluate some of these competencies? In the grant, we did write one at Vanderbilt and we were going to measure some of those competencies and dimensions, and that's what we wrote about, particularly in advanced practice nursing. What are the best models? What are going to be the best practices? I think yet to be determined, quite frankly.
Yeah, I reviewed that HRSA grant, and it's specific to nursing education, which is really neat. In medical education, it's kind of a free-for-all. There's not very many funding agencies that will put dollars for specific for simulation. There was a time where AHRQ and NIDDK had a specific RFA that was related to simulation. Some of those have passed and become more sophisticated now, but there's not as much for education research out there unless you tie it into another interest area. And we're faced with many of the same challenges you're faced with in nursing, as many of the listeners will know, that we have the milestones for our residents from the ACGME and the entrustable professional activities for our students. And it is a struggle. How do you measure them objectively? And simulation is often the answer, but for some of them, there are domains that are very hard to measure or are unknown on how to measure with simulation still, and more work needs to be done, such as teamwork or professionalism. Some of those domains aren't as easily measured in a simulation, and we have to be more creative and develop new processes. But my biggest pet peeve, though, is everyone is doing work in isolation. So maybe at Northwestern or at Vanderbilt, we have our system for doing it, but the other schools want to do it their way, and they do it their way, and they have the definition of how they're going to interpret the competencies.
Yeah.
And I wish we really had a national organization that would step down and say, here is the evidence-based way of doing it. Here are our milestones or our competencies, and this is what we want you to do. Here's the prescription, but they won't do that.
No, but I totally agree with you, Jeff. I mean, right now, this is new, right? Since 2021, and people are still trying to figure it out, the competency-based outcomes. But why do all of us at our schools of nursing have to reinvent the wheel over and over? And many schools of nursing may have 8 faculty, so they don't have time. They're just trying to keep up with the teaching and the students and the clinical and all that. Then on top, we put all this new curriculum work. It's not only are we moving to competency-based outcome, evaluation, but we also have new essentials. So you got to integrate that into the curriculum as well. So a lot of times, many people, if we had robust models, then let's just use them. wait, I mean, not to say there would be other models, but if I know of a, 2, 3 robust models, let's replicate that and get the data and continue to refine, right? Quality improvement. And I don't know, I can't speak for HRSA, but when that HRSA grant came out, and specific for nursing and simulation, wow, that's telling me something. They're looking to meet a need. They're looking, that was a high funding priority. And within that grant, we certainly did, and I mentioned this earlier in the podcast, and that's faculty development. So we inserted in developing an academy to develop faculty. And by the way, there was an interprofessional component. So we have Academy for Interprofessional Health Professions to teach and conduct simulations. But if you don't have the development, you can't just set up the mannequin or set up the room and say, go do simulations. It's not going to work. They don't know what they're doing. Rightly so. I wouldn't know either. So all of that development is important.
Let's talk a little bit, because my background obviously is in medical education, and I'm a little more naive to nursing education. And in medical education, we kind of talked about this. We call it the Oslerian model, where education is basically due to chance, vicarious learning episodes where you may or may not see it. But then also, the assessment, determining whether a clinician, a physician specifically, is competent to do something is very subjective. It's based on observation. And that's where simulation really comes in, is you can create these objective measurement tools to determine competency when it was really just based before on a seat of the pants kind of observation that was due to chance.
So, right. So in nursing, and whether that's similar in medicine, we have a lot of rubrics. We have a lot of evaluation tools, we've got Likert scales. Clinical education is always difficult. In fact, I remember the days at Vanderbilt, we used to grade clinical A, B, C. How do you separate a B plus from an A minus? And you're looking for safe practice, right? Safe, accurate, appropriate practice. I think it's either you do it or you don't do it. What degrees do you grade at? So we have shifted to pass fail on a lot of that. Many schools in nursing will go pass fail because it's too tedious trying to get those increments. Even on the clinical education side, if people go to simulation, and this is nationwide, it's not just one school, students have to pass, say, a head-to-toe physical assessment and making sure they're meeting that competency to conduct that physical assessment. And there's usually checklists, though, to do it. Did they do this? Did they do that? And if they miss out, I suppose there's a benchmark. If you only got so much percent and you didn't get upper level, then you got to redo it. Many times we'll say you need to redo versus just fail. And other schools say you got to fail, you got to retake the course. So there's a variance in that across schools of nursing. But what kills me is many times we want to hang on to what we think was great, the sacred cow. Like in nursing education, it's what we've always done. Taking students to the bedside. Back in my day, I first started having 10 students and it went down to 8. Now some units you can only take 1 to 6, particularly in pediatrics. Depends on the hospital. But there's no way I was always with my 6 students, 8 students, and at the end you just do the best you can. Or at least in simulations, I'm watching it, right? That is a great faculty student support because I'm watching them and I can see how they're communicating, if they're missing steps, if they didn't do the basic elements, whatever. But then I also can ask them about that in debriefing. And many times students were so nervous, they'll say, oh, I forgot to wash my hands. I forgot to do X. But I give them credit, at least they reflected and said, oh, I won't do this again. Because they did recognize it, but at least I could point that out. If I was on a clinical and they did something like that, I wouldn't always see it, right? But this was simulations. I do find you can evaluate them easier, but it's getting the tools and the inter-rater reliability. Those are the challenges. And then that's another thing in setting up and creating high stakes simulations. And you want to know, it's not that you can see people's brains working and know what they're thinking. So then you got to create the handoff, right? So they're going to verbalize what they're thinking. So you know if they looked at the potassium and see the hypokalemia or whatever, or, and maybe they're not doing anything about it, but, what were those labs? And maybe I have to create that in a handoff to get that piece of information. And if it went over their head and they didn't see it, then they didn't see it. That's a problem, because that was a prominent health disruption we should have recognized.
We will do diagnostic timeouts when we're teaching clinical reasoning skills, and then have the learner go through their thought process with us out loud. And it's like an instant, almost, I don't want to call it a rapid cycle deliberate practice, but in some ways it is, because you're going over it iteratively for multiple cases. But you're right, the hardest part about doing this is ensuring the inter-rater reliability. But it's much better than what we had before, which is, again, the seat of the pants or the observation that may be more subjective, that you don't have that inter-rater reliability for.
Absolutely. So we've crossed a lot of these bridges, right? And sometimes we, mended the bridge or whatever, but we still have a lot of opportunities to continue to work on, which we're doing, and I like that. And I like when we get together as health professionals to talk about some of these things, because what's unique in nursing isn't always just unique in our profession. It's unique across the health professions or what we're doing. And it is about a healthcare team. It totally is.
It's interesting that we're now experiencing some of the same issues with the competencies or the milestones and knowing what they mean and figuring out how to do them. And again, I just wish there was someone that came down and said, this is the way, but everyone has to figure it out. And I wish we had a national consortium that could kind of say, this is the way, or this is the way we're going to do it. I think nursing will be much more successful than the medical field in education and coming down with guidelines. They have been in the past, I think.
We've got a lot of evaluation measures, and we try to get data, to make informed decisions. So I do think we're on that, right pathway, and it's important. But we learn from each other too, and that's it. Challenge now. We've got a lot. The NCSBN study was about pre-licensure and the NCLEX, but we have a whole cadre of advanced practice nurses too, in the graduate level, and many times we need more evidence in that area and how to do. A lot from pre-licensure or medical education can still transition over into the advanced practice. But it's what evidence do we bring over and use within that population of advanced practice? So you've heard of the INACSL standards. I mean, INACSL standards are standards, right? Whether it's pre-licensure, medical, nursing, they're going to be utilized. They're evidence-based. They've got references. INACSL did a really good job getting all those documents and standards together, and that was very much a teamwork. But they're not for one population. It's not, okay, they're for pre-licensure, period. We're not going to look at them. It's for all of us. And any of these best practices, and Barry Eisenberg and team, I mean, they had the 10 best features, right, in simulation. You got that article. And it was so true. I mean, all that feedback's important. You can just go down the list of what those features are.
We need more of those standards and more of the how the nit and gritty. And you're absolutely right. We do need more faculty trained. And that's a big challenge, because a lot of people want to do sim, but it's not easy just to pick up and do sim. And I think that is going to be a major initiative, and we need more granting mechanisms for how to do these competencies and how to measure them. I did want to say that we have most of my practice in simulation is with graduates that are either in their residency or from APP standpoint, nurses or physician's assistants that are currently in practice. And we have been successful using the mastery model with nurses for procedural skills, in particular focused areas like in the ICU with vent management or with thoracentesis or with central line placement, et cetera. But it's usually very focused. And as you were talking about the pass-fail standards that they have in your nursing school as it being pass-fail, I was kind of wondering, how do you determine what a pass or what a fail is, or whether they have to do it again?
I think different schools, different faculty have different mechanisms. There may be some critical behaviors they have to do, and they have to pass those, right? I mean, if you're not getting 3 out of 5 critical behaviors, then that's a fail. I'm making this up because it's going to vary. It's going to vary, Jeff, across different programs, right? There's got to be some kind of benchmarks or some kind of parameters or guides. Go back to that checklist again. But I know I've graded students both ways, A, B, C, and then I've graded them pass, fail. Sometimes there's a fine line, and then what we've done, we brought them in the simulation lab too and say, need to demonstrate X, Y, Z. So we can use sims in that area too, or to remediate, because you're at this level and you need to be a little bit higher. And I'm not afraid to tell students that, because I'm concerned, especially if you've got 8 students and you're seeing them all the same in the sims and all that. This one's lagging behind. We need to work with them.
Yeah, and it's defining what is critical and what is not, right? I mean, I guess when I think of medical education, for me to get a D-level score on a biochemistry exam may be okay in the scheme of seeing patients eventually. Yeah. But to get a D on performing a central line insertion is not okay, right? Okay, so right. Maybe different things have higher levels of competency or what we determine as pass. And a lot of these questions are unanswered, and a lot of them are still just based on opinion. And we need to figure out a way to move away from opinion and make the more rigorous measurements that we can say are reliable. This correlates with better patient care in the end.
But we got a lot to do in measurement, I think, in metric. There's a lot of room for growth, potential. Again, across the health professions, just not in nursing, but all of us, and particularly in this competency-based realm of, looking at the outcomes. If that's what we're moving to, which we are, it's here.
I foresee a future where there will be specific requirements, not only in health professions education, but postgraduate, where practicing clinicians are going to be required to go through X number of sims to not only maintain their certification, but also to maintain hospital privileges and for the hospital to get Joint Commission's approval.
Yeah. And why not? If the public demanded it, then, or the market, the public, the institutions, it would happen.
Pam, as always, I learned a ton during this podcast and our discussion, and thank you so much for coming on and sharing your time with me.
Well, thank you, Jeff, and wish you all the best, and I look forward to hearing all these other podcasts.
So to our listeners, thank you for listening today. In future podcasts, we will continue to discuss key aspects of simulation healthcare education with experts in the field. Bye for now.